Hello, everyone. This is the Florida Medical Directors Association Journal Club on November 28, 2018. Our presenters will be Dr. Diane Sanders-Cepeda and Dr. Marianne Novelli. We are going to go ahead and proceed with today's focus being atrial fibrillation. We do have two articles. I will be presenting the first article, which is from the Journal of American Medical Directors Association. And this article is the impact of atrial fibrillation on falls in older patients, which is a problem existent or persistent. And it is brought to us from the kind people in Japan out of the Department of Cardiovascular Medicine at their Cardiovascular Institute and Department of Cardiovascular Surgery. So before we dive into the meat of the article, in their intro, they spent a lot of time discussing the pathophysiology of atrial fibrillation. So I wanted to just point out things that we probably already know, but as it relates to frailty, they're really hypothesizing that there is a decline in exercise performance in patients with atrial fibrillation caused secondary to hemodynamic deterioration. And because of this, we see that there's a decreased risk of fall. I thought it would be good just so that we have some reference of all the pathophysiological alterations that we can see in the atrium when we have a person with atrial fibrillation. So just for your reference, this comes from the European Society of Cardiology, and it just really goes through what we're seeing both at the extracellular matrix. We see fatty infiltration, amyloid deposits, in the ion channel alterations with remodeling that we see at calcium channel handling instability, down to the very muscle of the heart. We see hypertrophy of the myocytes. We may see necrosis. In the vascular, we may see microvascular changes, and all of this sort of goes back into feeding into that frailty syndrome. So this study was a single-center database study from a single-center database in their cardiovascular hospital, which means that they took all of the records, all of the information was from that single database, and that person who was included had to have presented to that cardiovascular hospital. It was derived from their patient records, and they looked at over 14,000 records. So the total population for the study was 14,056 patients between February 2010 and March of 2016. They then set their measure to be the incidence of falls within 3 years by baseline cardiac rhythm. So the group was divided to those who are younger than 75 and those who are older than 75. The younger than 75 population was 11,808, and the over 75 population was 2,248. And so I want you guys to know those numbers because it really means something as we start looking at their findings. They then further divided by heart rhythm, with the majority of the population being in sinus rhythm. They found the higher number of patients with paroxysmal atrial fibrillation, and then the remainder had persistent atrial fib. So when we're looking at the highlights of their population, as they were going through this data, more of their patients with persistent atrial fibrillation turned out to be male, and more of them had symptomatic heart failure. They more than often had chronic kidney disease and had a higher CHAS score as well. When they were collecting the data, they looked at the initial EKG of the chest X-ray, and then that was followed by the echocardiogram, a 24 Holter monitor, blood work. But what I found to be interesting was that was all at the discretion of the attending physician. So we didn't get all of the results for every individual. When they looked at some of their demographics, they also included hypertension, And if they did have hypertension, then they looked at the medications, they looked at diabetes. If they had diabetes, they also looked at hemoglobin A1C and the medications for those patients. And then they further looked into cardiovascular disease, structural heart disease, congestive heart failure, if they had a disabling cerebral infarction or a TIA. So what this study found, and it's really short and sweet and a little bit of a self-fulfilling prophecy, what it found is that those who were in the younger group had a less incident of falling than those who were the older groups. And this is a little hard to see, but this little yellow line is those individuals with persistent atrial fibrillation. So with this result, that information, they were able to determine that those individuals in the persistent atrial fibrillation group had a higher incidence of falls. Therefore, fulfilling that, as I said, self-fulfilling prophecy, that you're going to see more falls in those people with persistent atrial fibrillation. But what I found to be really interesting as I was reading through the study is that it felt more like we were making another hypothesis than a conclusion. And I think that leading question that they asked themselves about whether this is, where is this the problem? Is the problem existing or persistent? Really is important, because it feels like we've only answered a question that we already knew was a problem. You know, we haven't really got to the meat of what the real issue was, which leads us into the second study that we want to talk about. And I'm going to turn it over to Dr. Novelli. And Dr. Novelli, you just told me to advance the slides when you're ready.
Okay, thank you so much, Dr. Sanders. So we'll be talking about a paper that kind of pairs well with the first paper of atrial fibrillation. I think our clinical concern always when we have someone who is a frail elderly patient who has atrial fibrillation is what's the potential that we are going to cause harm rather than to improve health if we start a treatment for someone. And a big concern I think I've always had personally, and I think we all do clinically, is if I have a patient who is an elderly, frail patient, what is their risk? And am I going to cause a problem if I start anticoagulation? So this paper kind of addresses this. This is Dabigatran, Rivaroxaban, which is hard to say, and Warfarin in the oldest adults with atrial fibrillation in Taiwan. Now we can go to the next slide. This was a paper out of Taiwan, used the National Health Claims Database from 2011 to 2015. Now, interestingly enough, and I had not been aware of this until I read this paper, in Taiwan there is compulsory health insurance, and that's been the case since 1995. So every person in Taiwan has health insurance. So the claims database from 2011 to 2015 is actually comprehensive and covers all people in Taiwan, which is a remarkable source of data. It's a retrospective cohort study, and that has problems, and as all retrospective cohort studies do, but it is a really nice way of being able to look at a large group of data. And everybody who was aged 85 and older with a diagnosis of fibro flutter was identified and was put into the retrospective cohort at the time that they got a prescription for either Dabigatran, Rivaroxaban, or Warfarin. And just to review what those medications are, I think the next slide, please. Okay. Just to review what these medications are, Warfarin is a vitamin K antagonist. Dabigatran, which is also Pradaxa, is a direct thrombin inhibitor, and Rivaroxaban, which is Xarelto, is a factor Xa inhibitor. Now, if you just look at the names, this is just a little trick, but if you just look at and it has to be the generic names, not the trade names, if it has the XA in it, like Rivaroxaban or Apixaban, which is Eliquis, or Adoxaban, which is Savesa. If it has the XA in it, then it's a factor Xa inhibitor. Dabigatran is a direct thrombin inhibitor, so it doesn't have the XA in it, but it gets confusing because Dabigatran is called Pradaxa, which does have an XA in it. And the XA is for factor Xa. So you got to keep that straight, but it's just something to know about the naming conventions of these. Either they're called novel oral anticoagulants, the NOACs, or the direct oral anticoagulants, which is DOACs. There's been some controversy in the literature about should you call them NOACs because no implies no anticoagulation, or should you call them DOACs? There's been a lot of hand-wringing about that, but I digress. So let's go forward with the study. So what they did is to look at everybody who was over the age of 85, and they looked at them. They have a huge amount of data. These are the data in all the groups, and you can see how many different things they were able to look at because they have such a large data set. If you can go to the next slide. So they looked at all the comorbidities. It was actually really a huge amount of information regarding the composition of these patients who were over the age of 85 in Taiwan. Keep going. So you can see everything in terms of all the medications that these patients were on, and it's not surprising that they were on a number of cardiac acting meds because, of course, these patients have atrial fibrillation, so they might be on a number of different cardiac meds. Next slide. And this is just to give you an idea of what information they have available. So how often were they seeing their physician? How many times were they hospitalized? Were they on other medications, including non-cardiac medications? Keep going. And OADs is oral anti-diabetic medication. So they looked at, when you do a retrospective cohort study, if you do a prospective study, you can randomize people to one group or another group, and you can keep the cohorts the same. If you're doing a retrospective study, you unfortunately don't have that ability because you're kind of stuck with whatever the groups are that entered the study. Sort of, you're looking at it backwards in time, so you don't have the luxury of randomization. So what you have to do is use propensity scoring to kind of create random groups in one group or another to give you that same kind of randomization, but you're doing it retrospectively rather than prospectively. So you use the propensity scoring to do that, and that's what that PS match population is, because it's not unexpected that the group, if you look at it, if you look at the group without doing that propensity scoring, then it doesn't randomize the way you would want it to. Now, what they did is created two cohorts, the Dabigatran versus Warfarin and the Rivaroxaban versus Warfarin. Interestingly enough, they looked at only low-dose Dabigatran and low-dose Rivaroxaban, and they did that. They used a 110 dosing of Dabigatran, which is actually not approved in the United States, and there has been some controversy about why the lower dose was not approved in the United States, because the data do support using the lower dose. And they did that for, they also used the lower dose of Rivaroxaban. They looked at 10 and 15 milligrams of Rivaroxaban and then actually put those two dosage regimes together. They use these lower doses because less than 4% of the over 85-year-old cohort was using full dose dosing of either one of these DOACs. And that's, and it kind of gives you a sense that there might be some concern on the part of clinicians about giving the higher dose DOACs for these patients. There are also, and they had already excluded patients who had renal dysfunction, so the clinicians weren't doing renal adjustments of these dosings. I think that there was some concern on the part of clinicians that maybe the higher dose might have caused some problems. Then they looked at all-cause mortality, cardiovascular death, ischemic stroke rates, and AMIs, arterial embolism or thrombosis, intracranial hemorrhage, GI hemorrhage, and osteoporotic fracture. The reason that they were looking at osteoporotic fracture was they used that as a falsification analysis to make sure that they were looking at things that were truly true, as opposed to looking at data that that could have had a false conclusion. It's something that you can do with retrospective cohort analysis to ensure that it's a robust analysis. If you look across this table, you can see that in the all-cause deaths, there was a substantial difference in the rate of all-cause deaths in the overall population between warfarin and the DOACs. And then if you looked at the propensity matched cohorts, you can see that reduction is actually pretty robust. Between, if you look at warfarin, there is a higher all-cause mortality, there's a higher cardiovascular death, and there is about the same rate of ischemic stroke in all three groups. So what that's saying is that it looks like you're preventing the same amount of ischemic strokes. And they did not have, and this is one of the things that you can comment about the study. They didn't have the group that was not on anticoagulation. So they don't have a propensity matched population of people who were not taking anticoagulation and had atrial fib. And that, I think, would have been interesting to see what the all-cause mortality was and the cardiovascular death rate was for people who were not taking DOACs in the same group of elderly patients to really have a really more robust comparison. That being said, you can take the data from prior trials that have looked at mortality with and without an anticoagulant and have found that mortality is improved if you treat the underlying the stroke risk with the underlying atrial fibrillation. But it was interesting to me that all-cause mortality was so substantially diminished while appearing to protect at the same rate from ischemic stroke, despite the lower doses of Dabigatran and Rivaroxaban. Now, something that we all are worried about, and this is the same data looked at in a slightly different way, something that we all worry about is intracranial hemorrhage. I think that's something that is that everybody worries about when you have someone who is on anticoagulation. And if you look at figure F, you can see that intracranial hemorrhage, the very top line is the rate of intracranial hemorrhage with warfarin. And the two bottom lines, the very, very bottom line is Dabigatran. And the other line, the middle line, is Rivaroxaban, and that is the rate of intracranial hemorrhage. And so you can see that the rate of intracranial hemorrhage is substantially reduced on the DOACs. The panel G is GI bleed requiring transfusion, and GI bleed requiring transfusion is the warfarin line is in the middle, the Dabigatran line is on the higher end, and the Rivaroxaban line is on the lowest end. So it would appear that you have a slightly lower rate of GI bleed with warfarin than with Dabigatran. And that's consistent with other studies that have said that the intracranial hemorrhage rate is substantially lower using the novel anticoagulants, whereas there can be a slightly higher risk of GI bleed requiring transfusion when you use the DOACs, and so you have to use the risk-benefit. You know, do you accept that slightly higher risk? I think when you put that in light of the panel A, which is the all-cause mortality, and that is a really remarkable difference in all-cause mortality, and panel B, the cardiovascular death, when you use these agents, it would suggest that this might be something that we really do need to consider. I think we may kind of make a sense, we have an internal sense that the risk substantially outweighs the benefit in this old group, that these data are somewhat more convincing that we may be undertreating this group. Next slide, please. This is a little unclear because you have to note that the outcome, they did the top is Dabigatran versus Warfarin, and the bottom is the Rivaroxaban versus Warfarin. It's another way to present the same kind of data. If it crosses one, then the data are equivocal. And then you can see it either favors the DOAC or favors the Warfarin, and by and large, you see that there is substantial favoring of the novel anticoagulant for all-cause mortality and cardiovascular death, as we've mentioned before, for both cohorts, the Dabigatran versus Warfarin and the Rivaroxaban versus Warfarin. So in terms of the strength of this study, it is a really comprehensive database, and it seems like the data are really robustly analyzed. I think the limitation is, as they talk about, when you compare this to, when you compare any of the novel anticoagulants to Warfarin, you don't necessarily have a good understanding of the time that patients are in a therapeutic window, have a therapeutic INR, and that's always a concern when you have Warfarin, because with the novel anticoagulants, then you can pretty much guarantee that people are appropriately anticoagulated a fair amount of the time, as long as they're compliant with taking the medication, unlike Coumadin and Warfarin, where it's much more difficult to ensure that patients are reliably taking their anticoagulation in the way that it is indicated. They also only followed up their patients for 6.6 months, and certainly other trials have been able to follow their patients for a longer period of time, up to 2 years. I'm hopeful that they're continuing to follow patients so that they can develop this kind of data. And then they also note that this is a pretty homogeneous population, and it's an ethnic Chinese population. But nevertheless, they were able to conclude that these patients had a really substantial lower all-cause mortality and cardiovascular mortality than those who used Warfarin. Again, they did not compare this to those who had AFib and did not use any anticoagulation, but those studies are previously available in the literature and show that there is an improvement. But it does add to our body of information that suggests that perhaps we are in having an abundance of caution, we may be under treating our elderly patients. But again, we may not really understand the exact dosing that should be given to our elderly patients. So as most papers do, we still have areas to be looking at further. Thank you.
Thank you, Dr. Novelli. So we going to open it up to questions, but I wanted to just point out something that may be obvious to you guys now. When we're thinking about atrial fibrillation, we're often faced with the choice of trying to determine when to and how to anticoagulate. So we know there's a higher association of falls. I think we all would have that as part of our differential. But with this higher association of falls and the need to anticoagulate, you know, how do we manage and do everyday treatment for that older adult with atrial fibrillation? I think that is the predominant question. How do we treat the frail older adult with atrial fibrillation, and what factors do we need to consider? So with that, I open it up to anyone who has any comments or questions so that we can have a discussion. And if there are no questions at this time, please feel free to email us or talk to us, you know, through the app or email Jordan, so that we can definitely answer any of your questions. Dr. Novelli, do you have any other comments?
I think that we're still learning about what the best way is to treat us and treat these patients, and this goes back to having a conversation with your patients and their families, and having an understanding of the risks and benefits of each of the treatments that we offer our patients and our families, and doing some shared decision making regarding what the best way forward is for each individual patient.
Yeah. I definitely agree. And I think that we need to really look at more research in this realm of looking at the older adult, especially as our older adults are getting older. We need to really look at what does it mean to be frail, what does it mean to be to have atrial fibrillation, to have falls, to have all these other issues. How do we then manage it, go forward with a sensible and reasonable treatment plan, given, like you said, their considerations and what they want to do. I think it is very important to put that onus on that patient and that family member to make sure that they give consent to anticoagulate. We saw that being a problem a few years ago, so we want to make sure, especially in the nursing facility, that they are aware of the medications that they're being treated with, that they have properly consented to be on these medications, and they understand the risk factors of being anticoagulated and the risk factors of not being anticoagulated.
Thank you, everyone, for your attendance. We appreciate your participation, and we look forward to our next meeting. Again, as always, if you come across a paper that you would like us to discuss, or you would like to discuss yourselves, please let us know. We're always looking for people to participate and have an opportunity to speak about papers that interest them.